of tumors. I will say I've done a number of these webinars over the years, and I think this is the most esteemed panel that we've ever put together. And with that, I'd like to turn it over to our panelists.
Great. Thank you very much, Bruce. Long introductions, but yeah, I'm equally honored to be on the call with everyone today. So I think Derek and Katja, you are starting us off with providing some also visual background in terms of slides for everyone on the call. I don't know who's sharing the slides, if it's Cassie. Yeah, great.
Yeah, I got it.
Okay, great. Well, thank you everyone so much for joining. I think this is a very timely webinar to have with a lot of the updates that are coming for ETMR. I think it's great to see so many people who are excited about this and willing to join us to discuss what's going on with the tumor and where things are hopefully heading as we look to come up with better outcomes for children with this tumor. Go to the next slide. So as I'm sure most of you are all well aware, embryonal tumor with multilayer rosettes, or ETMR, is a very rare CNS tumor. It's also highly aggressive and tends to occur in very young children. Having worked with many families, I have seen patients all the way up to 12 years old who have had this diagnosis, but the vast majority, 90+%, are going to be in this very young age range of 4 and under, with the peak age probably being around that 2 years of age. Overall, this tumor has been associated with a very poor prognosis. Early on, you go back several years, majority of patients were not doing well with the current treatments. Unfortunately, we had high rates of relapse and patients overall not doing well. Thankfully, due to our improved understanding of this tumor and the collaboration that's taken place really across the globe with neuro-oncologists and working with so many families, we do have a better understanding now of this tumor and how to approach it. And I'm glad to say that we certainly are seeing improved outcomes. Patients are doing much better. We're seeing higher survival rates. So we are making progress, and hopefully we'll continue to build on that. ETMR is characterized by this molecular finding of amplification of C19MC. This is something that's found in about 90% of all tumors, but that does mean that there's about 10% who do not have the amplification. And then the other hallmark finding is high expression of Lin28, which seems to be pretty much a finding that we see across the board in about 100% of these tumors. Next slide. So initially, ETMR was grouped in this sort of large basket of tumors that we called PNETs. We didn't have the term ETMR. That came around just a few years ago in 2016. Prior to this, they were lumped under that basket of PNET, but also had unique individual names like atanter, meduloepithelioma, ependymoblastoma. And in 2016, the WHO was able to categorize these variety of tumors, which were all aggressive embryonal tumors that occurred in young children, and grouped them under the term ETMR based on this C19MC amplification, or tumors that fit the histologic profile under the microscope that may not have had the amplification. And that was really a big step forward for ETMR. We think of this as a new tumor, but obviously it's not something that just started happening a few years ago. Children have been been suffering for this tumor for a long period of time. We just didn't have a name to put to it. Then we had these variety of names that we gave to it, but because this ETMR entity was divided up among so many different types of tumors, we didn't have a way to really push the treatment forward for this disease. Because now it's unified under this name, we're able to learn more about these tumors and hopefully collect patient information as we're doing through various registries that'll improve our knowledge and move things forward. So it's already a rare tumor, as we're well aware, but The fact that we've been able to unify it helps to at least give us a good number of patients and cases to study that have been able to drive the field forward. Going back a few years, once we had the diagnosis of ETMR and had this unified name, there really was no standard treatment. Patients were treated following various common infant brain tumor protocols, such as the Head Start protocol. There's the ACNS 0334 protocol through COG. Over in Europe, there was this PNET high-risk protocol that was used in Europe, especially in France. So there's a number of these different infant protocols that really weren't ETMR specific, but were used for infant embryonal tumors in general or medulloblastoma. And so we just tried to apply similar therapy to ETMR. Clearly, ETMR is its own unique tumor. So taking this generalized approach that isn't specific, that we just use for other infant brain tumors, understandably was not optimal. We're learning now that this is its distinct tumor that has its own characteristics and needs to be treated in a very specific way. It's not surprising if we now treat other pediatric tumors, whether that's leukemia, other brain tumors, solid tumors, all very specifically with a protocol for that tumor, and the same needs to be done for ETMR. So knowing this, we had these general approaches. Most of these infant brain tumor protocols, the focus is to avoid radiation. So we give upfront chemotherapy, and then in lieu of radiation, we give high-dose chemo with stem cell transplant. Because we do this to try to avoid the significant cognitive effects and other late effects that we see from giving radiation to a developing brain. So because we're avoiding radiotherapy and taking this primarily chemotherapy and high-dose chemotherapy approach, we saw high levels of resistance to therapy. There was a high rate of early relapse. We have this Kaplan-Meier curve on the right side of the screen. These are the survival curves that we use to track patients over time. And you see that there's just this very steep decline that happens very quickly. Basically, within the first 6 months of treatment, we're seeing patients relapse and the disease not responding to therapy. And this is very different than what we see with most pediatric cancers. It's not that other pediatric cancers don't relapse, but typically we're able to get patients through treatment in most cases. And then the relapse tends to occur later after the therapy is completed and we're stopping the treatment. In the case of ETMR, it was just this very steep decline where it seemed like the tumor wasn't even responding to therapy at all. That was leading to the very poor outcomes. Now, due to some updates and better understanding of the tumor, we're able to adjust this approach and we're seeing better outcomes. But up until recently, this poor survival with early relapse is really a hallmark of the disease. So with that, I'll turn it over to Dr. Van Hoff, and she'll pick up from there and talk about some of the more up-to-date developments with the tumor.
Thank you very much, Derek. And thank you to the organizers having me in the panel, also representing the European group here. I think, as it was said in the introduction, collaboration is absolutely key here for finding better treatments for this disease, which is a very hard way for the families and the patients to go. And we would really be delighted and collaborate and find better treatments for the patients. So I would add to Derek's introduction and give some further insights in the disease of ETMR. So here in the first slides, I have a summary from a publication from Marcel's Holtz group from Nature 2019, just to give an overview. Derek already explained that there is a typical for the disease that is happening at a very early onset within the first 4 years of age, typically. It was also explained that in the historic series, there was a poor prognosis. Important to know that the tumor can grow in every side of the brain, so there's no direct predilection that can happen supratentorially, infratentorial, in the cerebellum, but it can also happen in the brain stem, and that causes a different way one can approach the individual patients, because not all locations are amenable for a full surgery, for instance. Some of the patients also present with metastasis in the beginning, so this creates also a different clinical setting. what has been explained, this C19 microcluster amplification, what does that mean? That is on chromosome 19, a region with an doubling or a multiplication of information, and that information codes for microRNAs. What are microRNAs? MicroRNAs are short, non-coding pieces of information, and they regulate the gene expression. So they regulate what is read from the information in the gene. And we know that this tumor, ETMR, is characterized by a dysregulation of this microRNA processing. So as has been said, 90% of the patients have this C19 amplification, but there are other patients that have other drivers to this form of dysregulation, and that might be a DICER1 mutation, but that might also be a microRNA dysregulation problem with other microRNAs. I don't want to go into details here more. As you have heard, we have Marcel Kohl and also Mariella Filbin here in the panel. So they can later on give more information where we are here with the information, what further knowledge is needed, because the goal of all these evaluations on the microbiology of the tumor, to the molecular biology of the tumor, is that we want to improve the way we can stratify patients, the way we can predict the individual prognosis of this patient to better adapt the treatment. And of course, we also are very much interested to introduce new treatments, new drug combinations. And for that, we need the knowledge of all the patients. So what else did we learn on this tumor type so far? We learned that that's a very rough estimate, that it's about 1.3 patients per million children in this age group of 1 to 4 years of age that develop this tumor. So it's really a rare disease. If you calculate it on Europe, it's about 20 patients per year in Europe. But as said, the presentation can be very heterogeneous, where it presents if there's metastasis or not. So it's not a fully uniform group of patients. When you look for sub-cohort analysis from historic series, with historic series, I mean what has been presented, that patients were treated with a kind of an old protocol or standard protocol for another disease. And then you go backwards and you look what kind of treatments did these patients have. So you see that the patients who profited most from treatment were patients with a combination of high-dose chemotherapy and radiotherapy. Of course, it's always hard to look backward and try to learn. It can be dangerous. And that's just to show one of the series. That's from the Rare Brain Tumor Consortium cohort. That's coordinated from Toronto group. And they had a large cohort of 108 patients. And you see, if you just focus on the patients that were treated with high-dose chemotherapy and radiotherapy, they had a quite better outcome than patients if you look in the full cohort. But when you reading such numbers, it's always important to understand that the patients in these curves are just a very small subcohort. And here are the numbers of patients at risk. So of this full cohort of 108 patients, it's just about 14, 15 who actually were in this good curves. So next slide, please. So when we look at the data, and what we think currently is that there's really an important role of early post-operative radiotherapy. We think that radiotherapy is effective for this disease. but we know that radiotherapy also comes to a price, and that again depends on the site of the tumor, the size of the tumor, how large is the irradiation field that is being given, how old are the patients. And it's important to note that there are also patients that survive the disease without radiotherapy. So that is also a question for the future. How can we predict this? And the curves that are given here on this slide show the German series of 35 patients, and these are patients with an intent to treat analysis. So here in this curve of the upper curve, you see patients that received an induction chemotherapy and an high-dose chemotherapy, or they did not receive the high-dose chemotherapy because they were progressive before. And that's the typical flow sheet if you analyze such data, that you start with one treatment and a lot of patients already are progressive under the treatment. You give the next treatment, and again, another proportion of patients, they're just treatment refractory. We would like to understand which patients are treatment refractory and how to better treat them. But what you see here of the patients who made it through this treatment and where treatment was ended, there were 5 patients who did not receive radiotherapy treatment because that was not foreseen as a standard in the protocol, and 3 or 4 remained free of disease. NED means no evidence of disease. The question if radiotherapy is introduced earlier is a relevant question. If one looks back to mixed data, it's nevertheless also happens that even after radiotherapy, there are patients who immediately progress. So what are the current standards of care recommendation for patients in Europe? We had built up a panel and discussed this. How can we use the current information and come up with a recommendation? One goal is, of course, we would like to have a trial where we can learn more and be better with our treatments. But for patients that cannot be included in a trial or in the time before a trial is open, we still would like to provide any guidance for the treating physicians, how they best could approach the patients. And that is a very abbreviated version here. So I really give this just with the caution that it's really abbreviated, but nevertheless, it's a kind of basic. So in terms of resection, it's recommended that there's a maximal safe resection. If the maximal safe resection is not possible in the first surgery, we would recommend to discuss a re-resection, but importantly, the re-resection should not delay the start of treatment, because we are very aware of that this disease needs a tight treatment. You cannot afford to have pauses in between. So we would not recommend to make a long pause to plan for a re-surgery. If that's not immediately possible, we would recommend to go on and proceed with chemotherapy. So if direct re-resection is not possible, we would recommend an early start of chemotherapy treatment. With regard to radiotherapy, as said, we think that radiotherapy is effective. We recommend to combine radiotherapy with a multi-agent chemotherapy and give the radiotherapy early in the course. Again, also this not necessarily means that the radiotherapy is given as the first treatment, because that usually also takes time until radiotherapy is planned, and chemotherapy is usually faster to start with. And as you give it in the combination, anyhow, usually we would start with chemotherapy treatment. For young children with non-metastatic disease, there's a recommendation to use local irradiation. For older children, it's unclear at that point if craniospinal irradiation, including the full brain and the spine, is maybe favorable or not. The data are just not sufficient to give a clear recommendation here. Maybe local irradiation is sufficient. We don't know. There are few radiotherapy long-term survivors as outlined. We made very clear that as a prerequisite for a radiotherapy avoiding approach, a gross total resection should be achieved, so the tumor should be completely resected and a high-dose chemotherapy should be applied beforehand. And with regard to chemotherapy, we stated that a myeloablative chemotherapy, if this is planned, myeloablative means that you need an stem cell rescue, so a high-dose chemotherapy with a stem cell rescue. If this should be used, this should be used prior to radiotherapy. But it's again not clear what's the role of this. Some regimens that may be used include the mentioned regimens, and so far we have no comparative data. And some investigators have explored the use of intraventricular and intrathecal chemotherapy. Again, here's currently no evidence if this is really superior. It's somehow expected, but it's not proven. So next slide, please. So when one wants to improve treatment, it's always good to know the questions we have at the moment. So as said, with current treatments, we know already that we can treat a proportion of the children sufficiently, but we don't know which children on the beforehand, and there are certain questions that are not clear now. So how can we optimize current treatments? One question would be if there is a benefit from receiving high-dose chemotherapy when radiotherapy is applied. As said, for the older patients, it is a question if local radiotherapy is sufficient, if there are no metastases. It is a question if patients benefit from intraventricular chemotherapy. It is a question if there's a benefit with the use of maintenance chemotherapy with the different agents that have been tried so far. And that is the question, how can we improve the treatment we have at the moment? The even more important question is how can we rapidly translate new knowledge in better treatments? So the question, how can we find prognostic and predictive biomarkers to identify patients that may profit from new drug combinations upfront? A very important question is also, can we use liquid biopsy as a minimal residual disease marker for stratification of treatment? Just recently, and that's the publication mentioned here from Madlena et al., published last year, it was shown that from the blood of ETMR patients, you could evaluate for a microRNA, for a specific microRNA, and this gives an impression how large the tumor mass is in the patient. So we hope that in the future we can use this kind of liquid biopsy evaluation for better prediction and also for the stratification of treatment. So of course, the goal is to introduce a biomarker-driven early phase clinical trial with new drug combinations. But of course, the evidence must need in the right place so one can set patients in such a trial. And also a question is which patients profit from immunotherapy. And these are the questions we would like to solve together in a collaborative effort in the future. And with this, I want to give the word back to Derek Hansen.
Okay, thanks. So, as we mentioned earlier, leading up to today and some of the newer advances and understanding that Dr. Von Hoff just outlined, we had ETMR being treated by physicians all over the globe with a number of different protocols. There really was no standard or uniform way that this disease was being approached. We did have some retrospective analysis come out. We've shown the survival curves, including this one from the Rare Brain Tumor Consortium, where they did collect information from over 100 patients. We're able to look back and start to gain insights. It's really difficult, as Dr. Von Hoff mentioned, to sometimes make treatment decisions based off of retrospective data, it can sometimes get muddied and not always give us the clearest answer on the way forward. And that's why we like clinical trials that give us prospective data. But we did have this retrospective data, and it showed something that to me was very striking. So this survival curve that we have up, I'm going to focus on the solid blue line. So these are children with ETMR who had a gross total resection. So the tumor was completely removed and then went on to receive treatment that included high-dose chemo with stem cell rescue. And as we look at this curve, again, we see this very steep decline. About 6 months into treatment, about half the patients have already relapsed. And so again, we're seeing a lot of treatment resistance, poor outcomes. If we can't even get the patient through therapy, how can we possibly expect a cure? And so we see that there still are some survivors with this high-dose chemotherapy approach. About 21% of patients go on to be long-term survivors. But that means 4 out of every 5 children treated with this approach ultimately relapses and has a poor outcome. And so we need to do better than this. I don't think anybody's happy with a 21% survival rate. Next slide. So here we have another survival curve again from this Rare Brain Tumor Consortium analysis. Now the solid blue line is focused on patients who received gross total resection, high-dose chemotherapy with stem cell rescue, but they also received radiotherapy. And now if we take this out to 6 months, we see that there's been very few patients who relapsed. This is a small cohort, only 14 patients, but we have only 1 relapse out of 14 patients. And then if we take the survival curve out further, we see that there's a 66% long-term survival rate. And so these are both curves that I just showed you are children who had a gross total resection. They received high-dose chemo with stem cell rescue. The difference between the two groups, one with the very steep drop-off in the survival curve and the other that has this fairly good, for ETMR, survival of 66%, the difference is radiotherapy. That's the only difference really between these two groups, looking at them as a whole. And so that told me radiation, which we've generally been avoiding in children with with infants and young children with brain tumors, is probably a really important part of therapy, if not the most important part of therapy for ETMR. Next slide. This just shows the overlap of the two curves. And again, the stark the difference between the two groups. Next slide. So with that in mind, we decided to move forward with this international trial, PNOC 31, which is a globally focused trial on ETMR. And this was something that we had been discussing for many years. The goal was, one, we wanted to be able to study this tumor prospectively. Let's get data where we're collecting information on patients from diagnosis and following it out. That's really the gold standard for data. We wanted this to be a global collaborative effort. This is a rare tumor, and so if we're all acting within our own silos and not sharing information and not all pulling in the same direction, it's going to be very difficult to accrue enough patients. It's going to take a long time to get to any conclusions or changes in therapy. And so the focus was to really make this an international effort, not just within the international sites in PNOC, but really within sites across the globe. And so that's a big focus on this, is we all want to work together, pull in the same direction, share resources so that we can move things forward together for this tumor. As I mentioned, radiotherapy seems to be a critical point of treatment for these patients. And so the first clinical question that we're going to answer with this study is looking at the use of early radiotherapy in a small pilot study. But that is only going to focus on a small portion of ETMR patients. ETMR comes in so many different varieties. It's one tumor, but it occurs in different age groups. So a 4-month-old is not going to be treated the same way a 4-year-old would. Patients have a supratentorial tumor that's going to be managed differently than an infratentorial or a brainstem tumor. Patients who have localized disease are going to get a different approach than metastatic disease. And so there's really no one-size-fits-all approach to this tumor. And so in designing this study, we wanted to be able to have flexibility so that whatever child was enrolling on the trial, we could give them the best possible treatment for them, rather than trying to fit them into a fixed protocol that may not really be in their best interest. We want every child who's on this trial to be receiving the best treatment for them. So in addition to this pilot study for radiotherapy, we're going to continue to collect prospective uniform data on all patients, regardless of whether they qualify for the pilot study or not. And the importance of this is that, again, we're going to give each patient the best treatment for their particular case, but we still want to collect that data, and we want to collect it prospectively, because that's how we're going to move the field forward. If we have this really good prospective data set, when new drugs are on the horizon and look like something that would potentially be good for this tumor, we want to have a nice data set that we can use as a comparator, so we can actually determine whether or not this new drug or this new treatment approach is actually beneficial. It's also very critical that we collect tissue specimens from patients. This is a rare tumor. Every single tumor specimen is precious and can help drive the field forward and allow for more diverse preclinical studies to be done. A lot of the limitation with this tumor is that for a long time, we really only had one good cell line, the BT183 cell line. And there's no real indication that BT183 is representative of ETMR as a whole. We know this is a very heterogeneous tumor, especially based on the way that patients end up behaving clinically. And so if we can get multiple specimens to the researchers like Mariella and Marcel, then it's going to allow for better preclinical studies where we can look at treatments in a variety of different cell lines and hopefully come up with conclusions that would be more applicable to the ETMR patient population as a whole. And so along with the tissue specimens, we are going to be performing a wide array of correlative studies with Dr. Filbin and Dr. Kuhl's labs, as well as the Gojo lab in Vienna, to hopefully make discoveries that'll push the field forward. And ultimately, we want this to be a platform study. So it's not just about answering this pilot study question about early radiotherapy. There's so much that we have to learn about this tumor. And so as we answer questions, we want to be able to rapidly include other clinical questions into the overall umbrella of the trial, so that we can continue to run studies and push the field forward for ETMR, not have to run a trial, wait for years to get the data, then spend years designing the next trial and have this take decades. We want to be able to move nimbly and quickly to answer questions for this tumor. Next slide. So as I mentioned, this is going to be open to all patients with newly diagnosed ETMR. We have the pilot study focusing on patients who have a gross total resection and are eligible for early radiotherapy. This will be cohort 1, and then cohorts 2 will include other patients, those who have a gross total resection, but may not be a good candidate for radiotherapy, to instead receive a high-dose chemotherapy approach. That'll be cohort 2. And then cohort 3 will be for patients who have residual disease after surgery or may have metastatic disease, and we'll continue to treat them, again, in the best way for that particular case. Next slide. Focusing on the pilot study, again, this is in patients with newly diagnosed ETMR who receive early radiotherapy. The primary endpoint is going to be looking at progression-free survival at 6 months. So if you recall those survival curves we were looking at, we saw that very steep drop-off at 6 months for the patients who did not receive radiotherapy. So in this trial, we're looking at a very short time point. Usually we're looking at things like 2-year survival, 5-year survival. Here, we're really looking at the 6-month time point. Can we prevent this early relapse in patients by getting radiation, which appears to be the most effective treatments, to patients near the front of treatment? And hopefully that will allow them to receive the remainder of the therapy and lead to overall better outcomes in the long term, because we don't have this early relapse. In order to do this, we actually don't need that many patients. It's a 20-patient pilot study, so it's very feasible. It's something that we should hopefully be able to accrue enough patients for in just a number of years. And so this isn't something where, I anticipate a decade from now we'll be looking at this data. I'm hoping that within just a few years of the trial opening, we'll be able to accrue the 20 patients. And again, because we're looking at such a short endpoint at 6 months, we'll be able to get an answer that will help inform future treatments for this tumor relatively quickly. Patients will be receiving an optimized induction therapy. So they'll receive 6 weeks of induction chemo. Again, this is going to be optimized for ETMR based on some of the preclinical data that Dr. Kuhl's lab has generated, showing which chemotherapy agents may be the most effective in this tumor. So they'll get 6 weeks of that induction treatment, then go on to early radiotherapy, which will be focal radiation just directed at the tumor bed, because again, these are non-metastatic patients. And it's felt that focal radiation is hopefully adequate for these patients and would decrease the long-term effects of giving more aggressive radiation like craniospinal. And then they would finish up after the early radiotherapy with an additional 6 weeks of induction chemo. And throughout this, we will be collecting biospecimens for correlative studies. Next slide. So this just gives a diagram of what I outlined in terms of the treatment plan. So patients receive their surgery up front, get a gross total resection. Then we quickly move them on to the 6 weeks of induction 1 chemotherapy, followed by the early focal radiotherapy, and then concluding with an additional 6 weeks of induction 2 chemotherapy. Next slide. This gives the outline for the chemotherapy. I won't dive into too much detail here, but basically it's 6 weeks initially. So week 1 and week 4 are more intense chemotherapy that's given inpatient in the hospital. We also will be giving intrathecal chemotherapy with topotecan and cytarabine. As Dr. Von Hoff mentioned, it's not clear whether or not intrathecal chemotherapy has benefit in this tumor, but in general, it's felt to be fairly low risk. And we really do want to try to prevent metastatic disease from occurring in these patients. So if we can treat any cells that may be floating through this spinal fluid, prevent metastases from occurring, that'll obviously be of huge benefit to patients. And so we'll be looking at this very aggressive intrathecal therapy and seeing how that impacts outcomes for patients. Next slide. And then focusing on cohorts 2 and 3. So again, these are patients who won't be part of the pilot study, but certainly will be very important for informing how to treat all ETMR patients moving forward. We want to be able to collect data on every patient and make sure that we can use that to inform future treatment decisions. Next slide. So for cohorts 2 and 3, the goal is to collect prospective outcome data. They will still use this optimized induction chemotherapy backbone so that we can collect data on how patients are responding to this induction treatment. Currently, there's no clear induction regimen that's superior one versus the other, but I think it would be really important to have this optimized induction chemo and be able to follow patients out prospectively just so that we can gain information that we can then use to inform future trials. Again, the key is really we need to get a good comparator cohort. So if we can enroll 20, 30, 40 patients within these groups over time, I'll have this nice data set of prospective patients that when it comes time for investigational agents and other approaches, we can have this really nice comparison group that we have really clean data on that can serve to help inform those future investigations. And as with the pilot study group, we'll be collecting biospecimens and doing extensive correlative studies. Next slide. So just focusing on the treatment outline for cohort 2, you can pull up the next slide, which gives that treatment plan. So these patients in cohort 2 would again receive surgery with a gross total resection, followed by 6 weeks of induction chemotherapy. And then very quickly, we would get them to 3 rounds of high-dose chemotherapy with stem cell transplant. After these patients are finished with the 3 rounds of high-dose chemo, they do have the option to move on to radiation therapy if it's felt to be in the best interest of the patient. Could be that perhaps this patient was very young when they were diagnosed, and we want to give time before administering radiotherapy to minimize the late effects. Or it could be that for whatever reason, physicians or families feel that delaying the radiation may be in the patient's best interest. They would have the opportunity to still receive radiation as part of cohort 2. And then for cohort 3, these are patients who, again, have either residual tumor after surgery or have metastatic disease. They would follow the general outline for either the pilot study cohort with the early radiation therapy or this outline for cohort 2 with the high-dose chemotherapy, depending on whatever was felt to be best for that individual patient based on family preference as well as the physician's insights. Next slide. And so this brings up the large number of correlative studies that we'll be doing as part of this PNOC 31 study. We're going to be collecting a lot of samples, doing a lot of analysis. And so at this time, I'd like to just invite Dr. Filbin and Dr. Kuhl to give their insights about some of the preclinical work that's being done in ETMR and what we can look forward to as a part of this study.
Great. Thank you, Marcel. If okay, then I'll just start talking about our collaboration and then give it to you.
Perfectly fine.
Great. So like in the clinical, on the clinical side, also on the preclinical and basic science side, we've been collaborating for many years now, and especially Dr. Kuhl, Dr. Johannes Goya, and myself's lab have really realized we have to share our samples from patients, but also the few cell lines that there were, and generate new ones and establish techniques for this very rare tumor, as has been mentioned. We have realized in the last few years that this tumor in particular hijacks a lot of the normal embryonal brain development pathways, meaning this tumor has found out how the normal brain develops and uses some of this information to grow out of control themselves. And we are in the process together between the 3 labs to use that for new therapies. However, this is a little bit too early to incorporate into this particular clinical trial. But for this particular clinical trial, we're excited to divide up and conquer the work between the 2 different continents or the many different continents, and have established respective assays in our labs. And I'll give it now to Marcel Kuhl to tell you more about the details.
Thanks a lot, Mariella. I totally agree, and as already introduced by Dr. Hansen and Dr. van Hof, over the years, our labs, we have done a lot of studies on ETMR. That has led to a much better understanding, but there's still more work to do. That's why we need more samples to analyze those tumors. Also, there are new techniques on the market, like single cell sequencing and other methods that we get a better understanding of those tumors. But ultimately, what we want is to find and use this new understanding to find new treatments and better treatments and more effective treatments. And as Doric Hansen said, the big limitation in the field was that we didn't have too many models to test these new treatments, because all the new ideas that we get from all the genomic studies, all the profiling studies, all the sequencing studies, we want to test, but we cannot test that all on children. So we need to test that first in our laboratories, either on cell lines or on mouse models. But these were not existing because ETMR is a very aggressive tumor growing in patients. But unfortunately, when we try to grow these tumor cells in the lab, either in culture, in vitro, in a petri dish, or we injected tumor cells in mice, it was for a long time difficult to grow them and establish them as good preclinical models. So we focused a lot of our efforts on getting the conditions better and getting these cells also growing better in vitro, but also in vivo in mice. And I can say that we do pretty well now. We have established many more in vitro models that grow as cell lines or as so-called 3-dimensional organoid cultures in vitro. And we use those preclinical models now to test new treatments. But also we want to test our current treatments that we give to the patients and get a better understanding why do many of those treatments actually fail. As you see, the prognosis of these patients is still not good, despite the intense treatment that we give them. We give a very different chemotherapy using a lot of different drugs, and we want to get a better understanding also which of those drugs actually work best and which do not, and what are the resistance mechanisms that these tumors quickly develop when giving these high-dose chemotherapy. And that's where we're also testing on our preclinical models in vitro, where we can screen a lot of drugs and we can test new combinations, also coming out of all the sequencing studies that we do with the lab of Dr. Filbin and Dr. Gurio and others, but also then prioritize the most effective drugs, the most effective combinations, and test those also in an in vivo setting in mice. And that is, in a summary, what our labs are currently focusing on, and hoping that once we have these preclinical trials, testing our models and in mouse models, that leads also to new strategies to test in patients.
Thank you both. Yes, it's going to be very exciting. Up until now, as we mentioned, there's been very few models. Many families have come forward and been willing to donate tissue from their children. That's certainly been very impactful in moving the field forward. But hopefully, with this trial, we will now have the ability to get cell lines going and collect samples from 20, 30, 40, 50 patients as we move this forward. And that is going to be a tremendous step forward for our understanding of this tumor. Also, just very quickly, Dr. Von Hoff had mentioned that Dr. Gojo's lab has been working on this biomarker that's a microRNA. That's something that we're going to be studying extensively in this tumor. Dr. Gojo's lab has shown this microRNA to correlate very well with disease burden in ETMR patients. So initially at diagnosis, this miRNA is very high in the blood. Patients then get the resection. They see the levels go down very low, in some cases undetectable. And then at the time of relapse, they see the miRNA levels start to rise. And so this, if we can validate this, that there's a strong correlation between disease burden and this microRNA, that can be very impactful as we look to treat patients, and understanding which patients are at risk for relapse, which patients may do better even when the scan looks clean. If we have that additional information, we can use that to inform treatment decisions for patients and hopefully lead to better outcomes. So that's something else we'll be looking at very closely in the PNOC 31 study. So just to wrap things up as a summary, again, this is going to be a large international trial spanning multiple continents. Our PNOC centers in North America, Europe, Australia, as well as sites in Egypt and India. But we're not looking to just stop there and make this PNOC-centric. We want to collaborate with centers, certainly from all over Europe, and Dr. Von Hoff is going to help us with that. But also sites across the globe outside of Europe as well. We want to cast a wide net, work with as many neuro-oncologists and institutions as possible. This is a rare tumor. Every case is precious and provides us with valuable information that can move the treatment for the disease forward as a whole. And so we really want this to be a very highly collaborative global effort. At present, the first question we're looking to answer is with this pilot study looking at early radiation in patients who have a complete resection. And all other patients will still be collecting data prospectively to have a nice uniform data set that we can use for future investigations. We mentioned the ETMR-specific miRNA biomarker that Dr. Gojo's lab is investigating, which may allow for minimal residual disease testing in this tumor. And again, collecting tissue from all patients so that we can have samples to further the overall preclinical efforts. But we're not just looking to stop there. It doesn't just end with the pilot study. We want this to be a trial that continues on for many years and answers additional questions for this tumor. So in the future, again, looking to continue and expand the international collaboration, work with investigators from across the globe to develop questions and trial designs that we can plug in to the PNOC 31 framework. We'll be looking at MRD testing to inform risk-adjusted therapy for these patients. So if we can validate the miRNA biomarker, we can then use this at the end of therapy to look, and we can see, if there's no sign of this miRNA biomarker, that could mean a very good thing for the patients. Maybe they don't need further therapy, or maybe we just put them on maintenance, versus maybe there's a patient who went through and got their treatment with high-dose chemo and the family's on the fence about radiation. Well, if we start to see the miRNA biomarker, maybe that means that we do need to be a little bit more aggressive and consider something like radiation versus a maintenance treatment. Ultimately, while we're very focused on upfront therapy at this point, we know that many patients will unfortunately relapse, and they are in need of better therapies and ways to approach them. Currently, there's absolutely no standard approach. And so we want to eventually incorporate a relapsed arm so that we can test novel agents and bring better treatment to patients who may have relapsed disease. And ultimately, we'd like to take these novel agents up front and get them to patients at diagnosis. If we have a new drug that looks really promising, that could lead to better outcomes, we want to get that to patients quickly up front as the first line of therapy once we've established that it's something helpful and beneficial for patients. So there's a lot coming down the road, but we're very excited to be launching this trial in the next few months, and hopefully it'll be a huge step forward for this tumor, and looking forward to collaborating with physicians from centers across the globe and working with so many of you patients and families as well, so we can all contribute to learning more about this tumor and improving outcomes for all the children that will be diagnosed with this tumor in the future. So with that, just like to thank everybody for joining and for your attention. And it's great that we have so many people participating in this webinar. It's really encouraging to see how enthusiastic everyone is about learning more about this tumor and moving treatment forward. And so we'd be happy to take any questions that you might have.
Thank you so much, everyone. So we have a lot of questions that have popped up in the Q&A. So I'm just going to go in order that they were received. So I think one of the first questions that came up was if we think there'll be chromosome aberrations only in tumor cells or potentially identifiable in the whole karyotype, such as through germline testing from umbilical blood samples as one example. So Dr. Hansen or Dr. Von Hoff, I don't know if one of you wants to maybe take that initial question.
Sure. So just to clarify, the question was, should we be getting umbilical cord samples on these patients?
I think it's more centered on kind of if we think they're only going to be somatic alterations or if they'll also germline alterations that might be in this disease.
Yeah. So in general, there doesn't seem to be a huge germline driver for this tumor, with the exception of there are some patients, these tend to be the C19 MC negative patients, a subset of them will have this dicer mutation, which can be germline and could potentially put them at risk for developing other cancers in the future. But it does seem like the majority of cases, especially those that are C9MC amplified, it's just a genetic aberration within the tumor cells themselves. It's not something that's germline throughout all the patient's cells. So in most cases, this is not a germline condition.
Great. And then kind of as a follow-up to that, and maybe Dr. Filbin, you can take this one. Given that, do you think at this point additional RNA or DNA sequencing should be performed to identify more targeted treatments and kind of maybe insight in addition to what Dr. Hansen touched on at the end on the role of liquid biopsy and how we can use that?
Yeah, thank you. That's a great question and exactly what we want to do in the context of this particular clinical trial. Maybe we were not specific enough, but a lot of RNA sequencing and DNA sequencing and microRNA sequencing will be done as part of this trial on the tumor itself, but also on the same patient's blood and CSF. So that's the fluid around the brain and spine. So we are hoping to learn a lot from this, and from judging from the few samples that we have already analyzed between our labs, Dr. Kuhl and mine, we are confident that we are able to do this. So it is doable, and now we're looking forward to doing this in a lot of patients.
In addition to that, what we also really want to understand better the resistance mechanisms, why these tumors become so quickly resistant to therapy.
Exactly.
Thank you. And so the next question I think is more of a treatment focused and trial focused question, which is if the patients are getting chemotherapy first in the proposed outline and radiation after around 6 weeks, what timelines are we considering to be in the realm of early radiation? So maybe Dr. Chi, you can take that one.
Hi, everyone. Thank you very much for joining and allowing me to take part in this panel. With regard to early radiation versus delayed radiation, this is really all quite relative. Obviously, 6 weeks after the initiation of induction chemotherapy is very early, and we would consider that early, but should there be high-dose chemotherapy followed by radiation, that many weeks later is obviously in the context of a child's life is not that much delayed, but for our study, and I think conventionally speaking across other infant tumor regimens, the delayed radiation usually comes after high-dose chemotherapy. I hope that answers your question.
Right. And then in terms of biospecimens related to the trial, how much tissue and what type of samples are we exactly hoping to collect to help be informative? I think either one of Dr. Kuhl, Dr. Filbin, or Dr. Hansen could take that.
I'm happy to talk about the tumor part, and in terms of CSF, I'll give it back to you. On the tumor part, the minimum required tissue we are hoping for is about 20 milligram, but we would also be honored to get even smaller pieces and then do only parts of the sequencing on them. And we would decide as a group which is the most important to do for a particular patient. And then for CSF, I'll give it to Marcel.
CSF, yes, we collect. I don't know the exact amounts, but they can really do the analysis on a really tiny little amounts. But and regarding the tumor tissue, what Mariella says, I completely agree. 20 milligram is a minimum. A little bit more would be preferable. But what we also really prefer is frozen tissue, but also, if possible, viable tissue. As I said, we still lack enough preclinical models. So we want to take as much as possible tumors into culture, either in vitro, in the petri dish, where we can really scale up all the different treatments that we want to test. But we also inject as much as possible of these viable cells in mice to develop mouse models. So viable tissue is really, really highly needed, but of course frozen tissue as well. And it's not always possible to have both. I fully agree, but whenever possible, yes, that's highly preferable.
Anything else that anyone else on the panel feels we should add? Okay. The next question, I think, Dr. Von Hoff, would be great to answer is, do we think that ETMR is on the rise? It seems like specifically this comment was from attendee from Poland, who commented that there's seems to be an increase in diagnoses, at least in that country. And how is it that this rare tumor seems to be rising in incidence, and is there research being done on that?
So yeah, thank you for that question, which is also really important and yeah, important to ask and to discuss. We don't think that the real frequency is on the rise, that there are now more cases with this kind of tumor, but we are aware of that in previous times there was not this high awareness. So we expect that previously some patients did not get the right diagnosis. That is the one. And the other thing is that what we saw when we went into population-based evaluations, going back and re-evaluating tumor tissue. So in our cohorts where we really had the impression we have a kind of a population-based frequency, that with this rarity of the tumor, you can have years where it's just more, 1 or 2 years, and then it goes down again. So it's hard. I would not assume that the true frequency is on the rise, but it's definitely, the more we document now, the more we learn on the patients that are diagnosed now, we will be able to learn on this for the future. But the first thing really is to have a precise diagnosis, to have molecular diagnosis for all children, even if ETMR is not suspected in the beginning.
Great, thank you. And then perhaps Dr. Hansen and Dr. Chi, there's generally been a lot of queries in the Q&A about, how do we think about maintenance? What types of therapies are we thinking about? Intrathecals and systemic combinations and things like that. I know we discussed today, we're trying to answer exactly some of these questions in the context of the trials. But can you kind of speak to that, maybe how we're thinking about this moving ahead, in the context of trial development, in the context of maybe novel agents and things like that?
Sure. So, maintenance therapy is something that, again, we don't have a lot of good evidence to support for or against, but it is something that we frequently do end up using when treating patients. The thought is, so these are very high-risk tumors that have a high rate of relapse. We do get patients through therapy, and there's no evidence of disease. It can be very anxiety-provoking for families to just stop therapy and sort of have to cross their fingers and hope that we don't see a recurrence. We don't know if maintenance therapy helps prevent recurrence or not. There's not enough information at this point. But the thought is, if we can continue to give lower doses of chemotherapy, they're typically oral, better tolerated drugs, there may be some benefit to patients. And when you do a risk-benefit analysis, given the high risk of this tumor and how difficult it is to treat in relapse, there can certainly be potential benefit, and the analysis may be in favor of giving some additional maintenance therapy. We use a variety of drugs. There's no one set regimen that's recommended. We've used DFMO, everolimus, varinostat, isotretinoin, among others, as drugs in combination, sometimes along with additional intrathecal therapy. But it really is anecdotal at this point. Hopefully, again, as we get this prospective data set where we have clear outcomes from patients who are treated uniformly and know what the long-term survival outlook is with this uniform regimen, we can then hopefully begin to design a study question to look at different maintenance protocols and how they might benefit patients and lead to better outcomes. But that's a little bit further down the road for the trial. We need to get the initial upfront data first from patients. But it is something that we're actively looking at and will consider as we design future versions of the trial. And certainly, you know, if you have children that are nearing the end of therapy and you have questions about maintenance treatment, you can certainly feel free to reach out to those of us on the panel. We can work and make recommendations, just keeping in mind that there's really no clear evidence to support it, and there's no one set regimen that's shown to be best. But happy to work with you and on an individual basis and come up with something that may work for your family.
Great. And then maybe Dr. Chi, one of the questions that was raised was thinking about the risk of necrosis when combining high-dose chemotherapy with radiotherapy. So maybe you can comment on that and how we might be monitoring for that and safety concerns in this trial.
Sure. I just wanted to piggyback on Derek's response. I echo, you know, his comments with regard to the role and potential benefit, but unknown benefit of maintenance chemotherapy. And the reason being, clearly the first early portion is where sadly many of our children relapse. But as you can also see from the curves, they don't flatten out or they don't plateau. And so we do lose many children even despite getting them through the initial therapy. And so this is where the concept of a maintenance therapy, similar to other diseases, could be very, very helpful. With regard to the capturing potential safety events, certainly our trial will be recording those, and there is always that risk of radionecrosis when we think about the usage of radiation therapy, whether the transplant portion is before or after. I think in our experiences of in other diseases using all these modalities, as well as certain chemotherapy agents that are known to carry that risk, the order or the sequence may be also important, but that is not to say that these things cannot happen regardless of when they happen. So we will be capturing them. Yeah.
Thank you. And then I think we probably have time for one final question. And so the question is really any trial for relapsed ETMR, but perhaps maybe just in addition to addressing that more globally, like how we might be thinking about, or how you all as experts in this field are thinking about once the tumor has come back. I know you touched on it some in the context of trial design, but really, you know, anyone that feels up to commenting on that.
I may start and give a comment. So what we know, if the primary treatment is started with chemotherapy or high-dose chemotherapy, if the patients are radiotherapy naive, there might be a chance that with using that radiotherapy, there might be a chance for a cure with that, but we are very much aware that this chance is very low. If the full treatment has already been applied and the patients relapse, we know that it's a very poor situation. And this is exactly the situation where we want to get better and where we want to get new drug combinations, where we want to get smarter treatments that can offer something, because at the moment we just can't. And that's a very hard situation for all, for the families, but of course also for all physicians involved in that. So that's a brief feedback from my side. I don't know if one wants to add, maybe Derek.
Yeah, no, I agree with that fully. Again, it's going to be case by case, and if radiation is an option still for the patient, that's probably the most important treatment that can be given in a relapse setting. But ultimately, as I mentioned, we do want to develop a relapse arm for this study. Both Mariella and Marcel are actively working on discovering new agents and bringing them forward to the point where they could be incorporated into a clinical trial. And once those drugs are ready, that's something that we'll look to rapidly bring forward as part of this trial. So unfortunately, there isn't many good therapies we can offer at the moment outside of radiation. But again, happy to work with families on an individual basis to see what might be a good option for their child. And certainly, as soon as we have anything that's ready preclinically to move forward, we're going to rapidly do that and be able to offer that to patients, hopefully through this trial.
And I just quickly want to add on the research side, Marcel and I have been working with one family in particular where we got longitudinal samples from the same patient. This was also a sample of a patient of Dr. Susan Cheese. In that case, we were able to look at the evolution of this tumor over time with different treatments. And from this one case, we have to learn more, of course. We've realized that over time, there's more stem cell-like tumor cells in the tumor. So they don't completely change the DNA or RNA, but they become more embryonal stem cell-like. And what that means, if that holds true for many patients, and what that means for future therapy developments, we still have to find out.
Absolutely, and I can also add from our side, yes, following up on all the genomic analysis that we did over the years, we have some compounds that we think are very promising. We are testing them but being effective in one model doesn't mean that it is effective in all patients. And that's why I said, and I keep repeating that, we need many models. And now we have a couple more models. We see why it is so important. Because having these treatments repeated in all the different models, we see in one model is responding extremely well, and another model is totally not responding, not at all. And we want to understand that also better and find the biomarkers that we give these treatments, and we have lots of potential options that we want to, and we eagerly want to test in patients, but we don't want to give it to the wrong patients. We want to give it to those patients that benefit the best and find the biomarkers that, okay, this treatment has a high chance to work in these patients, and other treatment not, and we should give something else. And that's why it's so important. And having a single drug is not going to cure a patient. We need smart combinations. And that's why we talk to pharma also that they provide the drugs, to combine these drugs. But an important aspect is there that we can kill these tumor cells effectively in our petri dish. But that doesn't mean that it also going to work in patients, because we have to be careful that it's not toxic to the patients, because that is really important aspect also. That's why we need the mouse models, but a mouse is not the same as a human patient. So there, again, there are a lot of issues that we have to deal with, because we can sometimes cure a mouse from a tumor, but it doesn't mean that we can then easily translate it to a patient. So that is all the aspects that we have to deal with.
So Cassie, I think that's the end of the Q&A.
Yes, I think we are good.
So listen, I just want to thank all of our panelists for their time, but more importantly, for their tireless and passionate dedication to improving the outcome of this disease for kids and their families who are facing it now and will face it in the future. It's encouraging and extremely hopeful to see this quality of global collaboration happening. I think that speaks well to the future breakthroughs that will happen in this area. And to remind folks that collaboration is not just amongst scientists, researchers, and clinicians. Collaboration includes patient families, it includes industry, and it includes philanthropy. And none of this work would actually happen without private philanthropy. So thank you to everybody who could join today, patient families, other attendees. There will be a recording of this webinar today that will be available in the next 24 to 48 hours. And thanks for supporting this incredibly important work. Thank you, everyone.
Thank you so much to all of our panelists. And again, to those that are attending, if you do feel that you would like to reach any one of us, you can visit our PNOC.us website and we can help facilitate you getting in touch with any one of the providers on this call today.
Thanks, everyone.